Case Study 2 will be looking at TMJ syndrome. This presentation is presented by Casey Curry, Amanda Freemo, and Tiffany Robinson. Ramandeep is an active 23-year-old. She works as a part-time nurse during the day and is studying for her postgraduate certificate in the evening. Ramandeep started to wear a plate at night after she began to experience jaw pain and headaches. Sometimes the pain radiated to her ear, and she would apply a hot water bottle to it to ease the discomfort. It was not until her husband mentioned to her that he heard her grinding her teeth at night while she was sleeping. She knew then that her headaches might be from temporomandibular joint syndrome, and she went to her dentist to confirm her thoughts. In addition to the bite plate, the dentist also recommended she continue with the application of heat, use NSAIDs when needed, and incorporate regular relaxation exercises throughout her stressful days. This presentation will be addressing the following questions. Briefly describe etiology, pathogenesis, clinical manifestations, natural history, prognosis, and treatment options for temporomandibular joint syndrome. What effects does heat have on nociceptors so that it makes a good non-pharmacological treatment for pain? Heat and cold treatments are both hypothesized to have an effect on the release of endogenous opioids. What are these chemicals and why are they hypothesized to be beneficial in the body? Using your knowledge of physiology, how do NSAIDs, analgesics, function in the management of pain?
What is TMJ syndrome? So TMJ syndrome is a malfunction of the temporomandibular joint, manifested as deferred pain in the face and ear, as well as headaches. The TMJ works on the side of the hinge to connect the jaw to the skull, and TMJ syndrome can be bilateral, but it's usually unilateral. The etiology of TMJ syndrome can be multifactorial, including psychological factors and physical. So some of the physical factors include occlusal abnormalities, such as missing teeth, crossbites, open bites, underbites, things of that nature. Orthodontic treatment, bruxism, which is grinding, and orthopedic instability. So this could be like gum chewing, grinding teeth, clenching, any trauma to the head or joint. So MVAs, whiplash, concussion, head trauma, and also aggressive intubations, joint laxity, and exogenous estrogen. This can include estrogen-containing birth controls and hormone replacement therapy. Some psychological factors include stress, mental tension, anxiety, and depression. All of these factors cause muscle contraction, clenching, and other physical factors that lead to TMJ syndrome. The pathogenesis of TMJ syndrome can be broken down into three main categories: TMJ dysfunction, TMJ inflammation, and TMJ trauma. So TMJ dysfunction is like disc erosion or dislocation. This is when the disc of the TMJ is displaced from the surrounding articular cartilage through movement of the joint. TMJ inflammation is more about cartilage damage and dysfunction, and inflammation can be a result of TMJ disease or secondary to TMJ dysfunction. So some things that cause inflammation could be an infection of the joint, different autoimmune diseases like rheumatoid arthritis, lupus, ankylosing spondylitis, and then of course gout and CPPD. TMJ trauma is a disc or cartilage damage. This could be caused by TMJ dislocation or different fractures of the jaw and surrounding bones. Clinical manifestations and treatment of TMJ syndrome. So some signs and symptoms are pain and tenderness in the jaw. This could be in one or both of the joints. So as I said earlier, it could be bilateral or unilateral pain. Aching pain in and around the ear, difficulty chewing or pain while chewing. This can sometimes lead to weight loss. Facial pain, blocking of the joint, which could include blocked open jaw or locked closed jaw, and clicking and grating sounds during opening and closing of the mouth. Different treatment options include medications, non-pharmacological interventions, and surgical medical procedures. Some medications for pain include NSAIDs, Tylenol, muscle relaxants, and opioids. Medications to relieve bruxism or grinding include tricyclic antidepressants. And then medications to relieve anxiety, depression, and stress include SSRIs and SRIs. Some non-pharmacological interventions are oral splints or mouth guards. This prevents the grinding and clenching. Physical therapy and counseling. Counseling can treat underlying anxiety and stressors that cause TMJ syndrome. And then the surgical and medical procedures include arthrocentesis. So this is injecting fluids into the joint to remove debris. Usually it's sterile water or normal saline. There's also injections of Botox, which can paralyze the surrounding muscles, which relieves some of that tension. Corticosteroid injections directly into the joint help relieve inflammation. And then arthroscopy and arthrotomies repair torn cartilage and tissue, and are also used to perform joint replacements of the TMJ. And then condylotomies also can help relieve the pain of TMJ, but they do not directly fix TMJ.
There is good prognosis for TMJs. Up to 40% of patients experience remission. Conservative treatment is effective for most patients, and only a small percent of patients have persistent signs and symptoms. Long-term pain could cause heightened sympathetic tone. The natural history is not well understood, but one trial followed the natural history of patients with TMJs over a 2.5-year period. Results showed that without treatment, almost half of the patient's symptoms resolved spontaneously. 1/3 had decreased severity of symptoms, and 1/4 of the patients worsened within that 2.5-year time frame and may have required more treatment for relief.
Let's take a look at nociceptors. They are sensory pain receptors triggered by harmful stimuli in peripheral tissues. The stimuli can include thermal, chemical, or mechanical, and these nociceptors can be found throughout the body. The way this process works is there is a stimulant that causes tissue injury. This triggers the nociceptors, which initiates an action potential in nerve fibers up the afferent pathway in A delta myelinated or C fiber unmyelinated, which is a slower pathway. This goes through the dorsal ganglion, up through the dorsal horn, to the spinal cord, the thalamus, and ultimately to the somatosensory cortex, where pain is registered. I also want to take a moment to note that the reason why referred pain occurs is when there are different neurons entering the dorsal horn, and referred pain is a common issue with TMJ. Effects of heat on nociceptors as a non-pharmacological treatment. Ultimately, heat activates thermoreceptors, which in turn block nociceptors. Additionally, heat causes vasodilation, which increases local blood flow. This in turn increases the temperature in this region, reduces swelling and pressure, and also removes nociceptor stimuli of metabolism and inflammatory mediators. This in turn also causes a release of collagen extensibility, and this allows joints to stretch farther before the receptors are stimulated and cause pain. Additionally, it increases metabolism, which propagates faster rate of healing. Another note I want to make is that if heat therapy itself is too hot, it in turn can become its own nociceptive stimuli and cause pain. So you want to avoid that when using heat as a therapy. This diagram nicely walks you through the benefits of using heat. Let's take a look at the release of endogenous opioids and the hypothesis that surrounds this and how it ultimately plays into pain control. First, let's take a look at immune cells. Immune cells have endogenous opioid peptides. There are three main types. There's a beta endorphin, also known as END, which is the predominant one found in the body. There is also meta-enkapheline, also known as ENK, or diorphin A, DYN. There is a hypothesis surrounding the function of endogenous opioids in the body and ultimately how this contributes to pain control. So let's take a look at this and how this would ultimately play effect into TMJ. Cells are recruited to the inflamed tissue by chemokines. So in this case, it would be going to like the jaw area. Then they release peptides when the cells are stimulated by a variety of factors, which can include corticotropin releasing factor, CFR, noradrenaline, or interleukin-1 beta. These endogenous opioids then bind to opioid receptors in either the central nervous system, peripheral nervous system, or non-neural tissue. These cells then return to the lymph nodes after they have expended their peptides. Ultimately, it is believed that this results in targeted analgesia at the site of inflammation. This is ideal because then you don't get systemic effects from opioids, and this is also created from your body, so a more naturalistic effect.
How do NSAIDs work? Nonsteroidal anti-inflammatory drugs, known as NSAIDs, are used to treat pain, fever, and swelling, and other effects secondary to inflammation. And they work by inhibiting the enzyme cyclooxygenase, or COX. That enzyme converts arachidonic acid into prostaglandins, thromboxanes, and prostacyclins in the immune response cascade. So NSAIDs are going to inhibit the actions that thromboxanes, prostaglandins, and prostacyclins normally would produce. So by doing that, you have less pain because you have less swelling. You have the action on the hypothalamus decreases fever, and anti-nociception decreases the pain perception. And that's how they work. So here's a graphic that kind of shows it a little bit easier to understand. You can see the arachidonic acid. There are two different COX enzymes, COX-1, COX-2. And NSAIDs block both of those except for one of the medications, which is Celebrex. It only is a COX-2 inhibitor. But most of the NSAIDs that we're familiar with work on both COX-1 and COX-2. And so it blocks that cascade of effects. Therefore, you don't have the thromboxane and prostaglandin effect that you normally would have. And that's how it works. So here's a list of FDA approved NSAIDs. A lot of them are familiar with. The aspirin is in the category of the salicylates. Then we also have like the naproxen, ibuprofen, ketorolac, meloxicam, and then down at the bottom, the selective COX-2 inhibitor is Celebrex or celecoxib.